This is Breakthroughs, a podcast from Northwestern University Feinberg School of Medicine. I'm Erin Spain, Communications Director at Feinberg. More than 1 million men are diagnosed with prostate cancer worldwide every year. More than 350,000 will die from the disease. For those with advanced metastatic prostate cancer, treatments are limited. But a new Phase 3 international trial shows that a genetic targeted therapy could offer new hope for patients with specific gene mutations in their tumors. Dr. Maha Hussain recently presented the results of this trial. She is the Deputy Director of the Robert H. Lurie Comprehensive Cancer Center of Northwestern University, a medical oncologist at Northwestern Medicine, and she leads the genitourinary program at Northwestern. Welcome to the podcast.
Thank you. Thank you for having me.
And I know you've been all over the world here this week. You've just came from Barcelona, and now you're here in Chicago. So thank you so much for making the trip.
My pleasure. It's been an amazing journey.
Describe the standard of care right now for these men when they're at this advanced stage of the disease.
Sure. So the good news is since the introduction of PSA into the clinic, the number of patients who are being diagnosed with metastatic prostate cancer has gone down. Having said that, still prostate cancer can spread, and which is what we refer to as metastatic prostate cancer. And when it spreads, it can go to different parts of the body. The most usual place is the bone, but then it can also go to lymph nodes. It can go liver to lung and other areas. The usual treatment for prostate cancer ever since the original discovery that actually came in from Chicago originally by Higgins and Hodges, that prostate cancer is very much dependent on testosterone, and therefore castration, as in suppressing the body's ability to produce testosterone, can lead to significant response. Unfortunately, metastatic prostate cancer, even when it's still in its early phase, tends to be incurable and likely to cause death for the patient. The lethal phase of the cancer is what we refer to as castration-resistant prostate cancer, which is really where this study was conducted. Now, in this situation, this is a cancer that, despite the fact that patients are on treatment, suppressing their testes from making the male hormone, their cancer is beginning to be resistant and is growing. And generally speaking, there are oral therapies, chemotherapy, and other medications that are targeting cancer in the bone and so on that have been FDA approved for the frontline setting that have been demonstrated to prolong life. Unfortunately, again, prolonging life is not equal to cure, and all of these patients are destined again to relapse, which is really where the space of the clinical trial that we just conducted was in the setting where patients have progressed already on frontline hormone treatment, they have progressed on second-line therapy, and as I will speak later in details, many of them have seen many lines of therapy, so they are very much end-stage disease.
And so the need for new therapies, as you said, it's great. There's
Absolutely.
A great need here.
It's an unmet need, and it's an area of extreme priority for us in the field.
Well, let's talk about this trial. It's called the ProFound trial, the first time a genetic-based therapy has been used to treat prostate cancer. Now, this was an international trial. It included 387 men. Just tell me a little bit about these men and the genetic makeup of their tumors and how the therapy worked for many of these men.
Absolutely. So perhaps I should begin first by highlighting the fact that the 300 plus men that were included in the trial were the patient population that qualified for the study. So we began first by screening patients internationally, looking at the genetic makeup of their tumor, and the tissues were either obtained from the primary original biopsy or resection of the prostate, or from fresh biopsies that were done from metastatic areas. And then the tumors were actually screened by a specific assay through Foundation One Medicine, special assay that was jointly developed for the study specifically to look for the specific alterations. Now, at the time we designed the trial, the areas that were, the genomic alterations that were well characterized as potential predictors for response to PARP inhibitors was BRCA1, BRCA2, and ATM.
And these are familiar genes for a lot of people.
Absolutely.
With breast cancer, ovarian cancer.
Exactly. Because if the BRCA genes have been in the sort of on the scene for decades right now, and from a risk perspective, and of course from a risk of cancer perspective, but also from the perspective of responding to PARP inhibitors. And so when we designed the trial, we decided that for the cohorts that we think are likely to benefit, we're going to have a specific cohort, which is what we call the primary cohort, and for the primary endpoint. And we were targeting basically delaying cancer progression. And the reason that's clinically meaningful is that if the cancer does not grow, then the cancer is under control, and that by itself can potentially prolong life and can definitely reduce morbidity for the patient. And then we wanted to be really inclusive, and we wanted to look at with other potential emerging alterations that we think that may be related to DNA repair, could these also patients who have those alterations will actually respond to treatment? So that's the cohort B.
The results were pretty exciting because, as you predicted, there was a response. The life was extended, nearly doubled for some of these patients.
So it was really very exciting to see because, like anything else, one size does not fit all. And just because we see benefit in one cancer, it doesn't mean another cancer is going to benefit. And that's been the story in oncology forever. You have drugs that can be working for breast cancer, but they don't work for colon, prostate, and so on. And so in this case, actually, the primary cohort, the data met its planned target, and there was doubling of the time to disease progression with a median of over 7 months, 7.5 months roughly. And that actually translated into a 66% reduction in the risk of death or progression in favor of the olaparib treatment by comparison to the patients who received standard of care therapy. And the standard of care therapy, these are medications that are available in the U.S. and internationally, drugs called enzalutamide or abiraterone plus prednisone. These are FDA-approved drugs in the second-line setting for patients with prostate cancer.
Well, let's talk a little bit about this drug that's used for breast cancer. The drug is called olaparib. How does it work? You're calling it a PARP. Can you tell me about that?
Yeah. So basically, human body, our cells have the ability to repair themselves. And there are different mechanisms where the cells can repair themselves. And clearly, the cancer cells can inherit some of these features of repairing themselves. Now, there are patients who have the BRCA-like genes tend to have difficulty with DNA damage, and therefore they depend on an enzyme called PARP to help them repair themselves. And so consequently, when you select patients who have tumors that have these potential vulnerability, then trying to block that enzyme using the drug olaparib, and there are obviously other PARP inhibitors, then could make the cell susceptible to death.
You know, this drug benefited the patients no matter the cancer location, prior treatment, whether the cancer had spread, the patient's prostate-specific antigen number. Why is that so important?
Well, because these are clinical features that would predict for prognosis for that patient. So, for example, a patient who have one spot or two spots on their bone is not the same as somebody who has a liver loaded with cancer. Someone who has a PSA of 5 is different than someone potentially of a PSA of 200. And the reason is it reflects the bulk of the cancer, the aggressiveness, the biology. Now, these are not very specific metrics, but they have been very prognostic and associated with outcomes.
And we just mentioned you are just back from Barcelona. You presented results of this trial at the European Society for Medical Oncology 2019 Congress. What was the reaction like there in Barcelona? As this hasn't been published yet, so this was the first time that people have heard these results. What was the reaction?
It was amazing. This was a featured session. It's called the presidential session, and this is really where high top results get to be presented. So I was honored to be the first author and the presenter of the results. Every feedback I have received from just about everybody internationally has been very positive.
You know, one thing to mention that this therapy, like most therapies, is not without side effects. And I'd like you to talk a little bit about some of the side effects that were documented in the trial.
So obviously, like anything else, when we talk about treatments, there are risks and there are benefits, and there is no treatment that has no risks. The good news is that overall the treatment was well tolerated. The side effect profile was fairly consistent with what was seen previously. The most frequent side effect that was encountered is anemia, and anemia is actually one of the side effects of these drugs. Having said that, the reason I believe it's likely to be more prominent in this patient population is, and for your audience, as I'll explain it a little bit more, one of them is the fact that when prostate cancer spreads, it goes to bone, and the bone has the bone marrow, and that's when the cancer tends to infiltrate the marrow, and obviously can limit the capacity of the marrow to generate blood cells. The other part is that this was a fairly heavily pretreated patient population. Large number of them have seen multiple lines of therapy, including chemotherapy, and some of them have seen 2 types of chemotherapy, multiple lines of oral therapy, and so on. So I think that's part of it. The good news is that the predominant side effects were not high-grade side effects, although they were higher than what was in the control arm. And one thing to point out is that these patients, in fact, were on treatment longer. And so, obviously, when someone is on treatment longer, you're capturing more information there. Any of the other side effects that were observed were generally low-grade side effects and were not, severe enough to cause problem. There was actually an incidental finding of pulmonary embolus that was seen in about 4% of the patients, and it was more in the olaparib-treated patients compared to the control arm. However, this is not a side effect that has been previously reported with olaparib, which is widely used in breast and ovarian cancer at this moment. And whether this is sort of something that is accidental versus related to treatment is really not clear. However, this is something that's been looked into in more details. The good news is none of these were fatal, and all patients actually who had the blood clots in their lungs continued on treatment.
Maybe it could even be a gender difference. Who knows?
Well, it's hard to know. I mean, prostate cancer is associated with what we call thromboembolic events. And so when people are on treatment longer, you may be able to capture these things. And whether they're related to the cancer or the drug, there's no way to sort it out.
And what about the cost of this drug? That's always another consideration.
Yes. And I'm actually one of those people who are very conscious about the cost. These drugs, no drug we give, by the way, oral agents in the United States is cheap. Okay, most of these drugs are expensive. I do not know how much the cost will be. Certainly your audience can check what the cost is for ovarian and breast cancer. If obviously the FDA approves it, and as you know, FDA does not regulate cost, the drug will hopefully hit the market, and I'm hoping that this will in fact be covered by patients' insurance. And I'm sure there will be some compassionate use programs and other ways of trying to get access to the patients.
And as you said before, this is something that you are interested in and that you do care about because you see patients from across social, economic, demographics. Correct.
And I would say the part that I think we have issues with, and this is certainly something that we see not just in Illinois, we see it nationwide. And in fact, the society that I belong to, ASCO, has usually a meeting with Congress once a year. And one of the biggest things we bring up is cost. And I personally believe that every U.S. citizen should have access to drugs, and cost should not be a factor in their care. And I know that my sentiment is echoed by many people. I hope that the laws somehow can be adjusted to address that need.
But in the meantime, now that the study's out here, as you said, this may actually change your field if this drug can be approved by FDA, because as we said before, there really hasn't been genetic approaches investigated for prostate
Right.
cancer.
And so this is the exciting part, and that's why I call it's a new world order, because this is the first targeted drug that is being used in a pre-selected population based on the genetic makeup of their cancer. So all of the therapies we have for prostate cancer generally have been directly or indirectly targeting the androgen receptor, which is the hormone therapies we use. But we don't pre-select for potential responsiveness, right? We don't biopsy a patient to say, are they going to respond to this androgen receptor targeted therapy or not. We do a one-size-fits-all approach. And this has probably been part of the reason why there's a lot of hormonal therapy being developed in prostate cancer, because prostate cancer continues to be dependent on androgen receptor signaling. Having said that, this particular drug, our class of drugs right now, and of course if it gets FDA approved, will be the first, again, targeted agent that has been approved in a molecularly pre-selected patient population. And I think that opens up the door not only in specifically this class of drugs, but I think opens up the doors for more targeted therapy in prostate cancer.
And you've been a part of many landmark studies in the past. Your career has been built on investigating prostate cancer. And I want to know a little bit about your background and how you got into this particular disease. It started when you were a resident working at a VA hospital?
Yes. So the ironic part, when I started my career early on, it was interesting that I wanted to be a hematologist, but then I switched to solid tumors as I was rotating through different hospitals. And I worked in Detroit. I landed in the U.S. in 1983. And from 83 to 86, I did my medicine residency at Wayne State University in different medical centers that they have. And this is really, I would say, when we got exposed to the ugly side of prostate cancer, where we were medicine residents and we're taking patients in because they have a cord compression, because they have renal failure, because their prostate is so large that the urine was being blocked, and so on, and different other issues. And so when I started my fellowship, I sort of worked at multiple hospitals, but one of them was actually the VA. And that's really where I feel like I got chemistry with GU oncology and prostate cancer, because it just seemed like it was unfair that there was beginning progress in a variety of cancers, but prostate cancer was not being really tackled in a meaningful way. And I think we've come a long way. And it's been fascinating, as I said, because in my times, I saw veterans that were World War I veterans. I mean, that was amazing. And this was like Grandpa, and Grandpa had prostate cancer, Yeah. But then I saw people who were Vietnam veterans, and these were men in their 50s, and they had prostate cancer. And one thing about cancer in general, and obviously prostate is one of them, it does not discriminate whether you're rich or poor, whether you're black or white, you are suburban or urban or rural or whatever, your ethnicity, nothing, your country, it doesn't matter. It can be a very morbid and deadly disease. The good news with it is I think there's been significant progress over the last, I would say, 30 years.
And the Robert H. Lurie Comprehensive Cancer Center has been part of that. We were awarded a $11.3 million 5-year competitive grant from the National Cancer Institute just in 2015. And it's for continued leadership of a specialized programs of research excellence called Spore in prostate cancer. It's only one of 8 in the country. Tell me about the work being done through the Spore and the work being done in general here at Lurie Cancer Center.
Well, I would say we have an amazing team. And this is really one of the reasons why I moved. I call myself a Motown girl. Pretty much spent most of my adult life in Michigan. And it was really exciting to come here and partner with the team that we have here of both basic scientists, clinical researchers, clinical specialists in different fields, and there's a fair amount of research that's going on, and it actually dates back to decades. In fact, yesterday we had the Chung Lee lectureship to honor Dr. Lee, who was one of the first PI of our specialized program for research excellence, Spore, at Northwestern University. So there's been a history and a legacy, and we are really growing the program as much as we can, attracting as many new investigators, and as I call it, fresh blood, because we need fresh brains and spirits to kind of take the lead and take the baton and move on. And as I tell my team, the sky is the limit. And clearly, no one person is going to be able to save the world by themselves, and working as a team and partnering with not just institution, but locally regionally and nationally and international to try to conquer cancer.
And you still have the opportunity to work with veterans here at the Jesse Brown VA Hospital.
Exactly. And one of our projects that was recently funded by the Prostate Cancer Foundation is I'm hoping that we will be shortly activating at the VA hospital to look at some of the mechanisms and potential environmental genetic factors that might predict for why some people have worse cancer compared to others.
I do love you saying this is a new world order when it comes to treating patients with prostate cancer. I'd love to know, what's your prediction for the disease in the next decade? What advances do you hope will be made?
I actually think we're going to increase the cure rate. And the reason I say that is like anything else, at this moment, advanced metastatic disease is not something we can cure. However, we can prolong life. And remember, we don't cure hypercholesterolemia, but people live with it, right, with medication. So I do think we're going to get to the level where people can live longer and longer. And as you know, none of us is going to live forever. And so if we can make people live long and live well, I think that would be the primary objective when it comes to metastatic disease. I also think that a lot of treatments that are valuable and active in advanced disease could be moved into earlier phases of the disease where the cure is possible. And so I am looking forward to all of these things moving in the right direction, and I would look forward to a world that is free of cancer.
Thank you so much, Dr. Maha Hussain, for coming on the podcast, sharing the results of this latest study. We're excited to see what happens from here.
My pleasure, and thank you for having me.
If you enjoyed this episode of the Breakthroughs podcast, check us out on Apple Podcasts, subscribe, and leave a rating.